Good afternoon, everyone, for this new episode of TransConnect. This is August 2023, and today we are going to talk about thromboelastography case scenarios. So earlier episode was about the basics of thromboelastography. Today, along with me, my colleagues, Dr. Ashna and Dr. Jaya are going to take you through this case scenarios of the TEG. And basically what they are going to do is it's going to be a Q&A session in which one of them is going to ask the questions and the other is going to explain it. And thereafter, if there are any doubts, you can put them in the chat box. So let's start with it, and hopefully this should be a helpful topic for all of you. So happy learning, and over to my colleagues.
Case scenario 1. The patient is brought to the operating room for abdominal exploration. Approximately 2 liters of hemoperitoneum was present due to damage to the right iliac artery, which was repaired. The patient's BP was stabilized and transferred to the ICU. He continued to ooze blood from his abdominal incision and a thromboelastography study was performed. Kindly interpret this study.
This is the patient TEG that is denoted by the black line, and this is a normal TEG. So before interpreting this TEG, we will first go through a normal TEG, which is denoted by 5 variables, that is the R time. R time denotes the initiation of clot formation, and it is dependent on clotting factors. Now we have K time and alpha angle that denotes the clot kinetics, and it is basically dependent on fibrinogen. We have maximum amplitude that denotes clot strength, and it is dependent on platelets and fibrinogen, but 80% on platelets. And then we have lysis 30 that denotes clot stability, that how stable is our clot, and it is basically dependent on the fibrinolytic system. Now, this is the patient TEG. We can see in this TEG that the R time is normal. So, there is no problem in coagulation factors. The clot is there's no problem in the coagulation factors. Then we have R time. R time is prolonged and alpha angle is decreased. So there's problem in clot kinetics, and MA is also reduced in this case. So there is problem in platelets. So basically in this case, platelets and fibrinogen, they are low in this patient.
So what blood products should be administered?
So in this case, we will administer cryoprecipitate and platelets to the patient. So we will administer cryo and platelets. Why cryo and platelets? Because there is problem in clot kinetics, that is the K time and the alpha angle. So both these variables are dependent on fibrinogen, and MA is also reduced, that is dependent on platelets. Why are we not transfusing FFP? Because our time is normal, so we will not administer FFP.
Case scenario 2. A 65-year-old is undergoing a complex cardiac surgery. At the end of the procedure, during closure of the sternotomy, the patient is noted to have diffuse bleeding from the sternum and skin incision. Multiple attempts were done to stop the bleeding, but all the attempts were unsuccessful. Thromboelastography was done, which showed slightly increased reaction time, normal maximal amplitude, and a 70% lysis after 30 minutes. What is the most appropriate next step?
So in this case, we have 4 options. One by one, we will go through each. So the first option is we will neutralize heparin with protamine sulfate. So in this TEG, as you can see, there is slightly increase in R time. So, anticoagulation is not much problematic in this case. We have increased lysis 30. There is 70% lysis after 30 minutes, which is showing hyperfibrinolysis. So we will administer an antifibrinolytic agent, that is tranexamic acid. We will not transfuse platelets and FFP to this patient. Why? Because there is normal maximum amplitude, and our time is also slightly increased. So we will not transfuse platelets and FFP, and also we will not initiate MTP also.
In this case, why is there a slightly increased reaction time?
So it could be due to as the patient is bleeding, so there might be some loss of coagulation factors, and also in this cardiac surgery cases, anticoagulation is given, so that could also lead to slightly increase in heart rate. But the problem basically here is in lysis 30. The TEG is showing hypofibrinolysis, so we will manage this in by giving antifibrinolytic agent, that is tranexamic acid, and maybe later this patient, maybe the patient requires FFP also, but now in this case scenario, first preference will be to tranexamic acid.
Case scenario 3. A platelet apheresis unit was quarantined due to an apparent opacity and loss of swelling on day 4 of collection. Swelling was visually judged to have a score of 0, but on the day of collection, the score was 3. Functional quality was tested by thromboelastography. Kindly interpret this TEG.
So in this state, we can see R time is normal, the K time is slightly prolonged, 3.9, angle is normal, and MA is decreased. There is problem in platelets. The platelet functional of that unit has been lost. And also, if we do not see the values and compare this TEG with a normal TEG, we can visually see that the MA is severely reduced and the K time is slightly prolonged. So in this case, the platelet function of that unit has been severely compromised and the K value has been deranged. So it denotes an overall hypocoagulable tracing on the TEG.
So using TEG to assess the functional quality of a single donor platelet unit is a novel method. Case scenario 4. A 17-year-old male met with a road traffic accident, developed epidural hematoma, multiple abdominal injuries and pelvic fracture. The patient underwent external pelvic fixation and transfusion of multiple blood products. The patient was stabilized and still on ventilator. A TEG was ordered and this was the tracing. Kindly describe this.
So in this case, in this TEG, you can see that all the values are deranged as compared to a normal TEG. If you see, the R time is prolonged, the K time is prolonged, the angle is less, and the MA is also reduced. So it is showing a overall hypocoagulable state of the patient. So in this TEG, as we can see, all the values are deranged. It is showing an overall hypocoagulable tracing. So we will consider transfusing FFP also, cryo also, and platelet also.
Is there any specific order of which component should be transfused first and which component followingly?
So we should transfuse platelet first, as we have seen in a cell-based model of coagulation that platelet act as a phospholipid surface for the coagulation factors to act. And so we should first transfuse platelets, then FFP and cryo.
Case scenario 5. A 14-year-old male presents with chief complaints of rash and notice spots of blood when he blows his nose. He is not on any medications or supplements. On physical examination, we are able to see petechiae in his lower legs and his nose also starts to bleed. A TEG was sent. Kindly discuss this.
So in this TEG, the red line denotes a normal TEG and this black line is your patient TEG. So in this TEG, as compared to a normal TEG, we can see that the MA is reduced and alpha angle is also reduced. So by seeing this, we know that there is problem is in platelets. So we will consider transfusing platelets to this patient.
What could be the differential diagnosis in this patient?
So as we can see in the, as per patient clinical history, there is a petechiae, there are bruises, so there are superficial bleed. So it is probably a bleeding disorder due to a platelet function defect.
Can we do any specific platelet function tests?
Yeah, we can check by platelet aggregometry. by ristocetin at ADP, we can check for platelet function defect, where there are various platelet function defects like Bernard-Solia, Glanzmann's homocysteine, and granule defect that we could differentiate by platelet aggregometry.
Case scenario 6. A 26-year-old male comes to the emergency after sustaining multiple gunshot wounds to the chest. The patient was first stabilized and after resuscitation, a TEG was sent. Kindly explain this TEG.
So in this state, as we can see, first we should know that the red line denotes a normal TEG and the black line it denotes the patient TEG. So we can see that it is showing hypofibrinolysis. First, if we see this patient TEG, we see there is increased fibrinolysis and MA is also reduced. So it indicates rapid fibrinolysis. So we have to administer antifibrinolytic agent, that is tranexamic acid. This is a case of acute traumatic coagulopathy, which can occur early after injury in the setting of hyperperfusion, and it is thought to be independent from coagulopathy, that is secondary to acidosis, hypothermia, or hemodilution, and it is thought to be caused by dysregulation of protein C.
Case scenario 7. A 42-year-old female arrives in the emergency after a road traffic accident suffering from multiple injuries. After stabilizing the patient while intubation, a resident noticed that she has significant bleeding around the site of her IV line. A TEG is sent. Kindly interpret this.
So in this TEG, similar to other TEG that we have seen, that the red line is the normal and the black line denotes the patient TEG. So you can see as compared to the patient TEG, all the values are deranged. The R time is prolonged, the K time is prolonged, the alpha angle is less, and MA is also less. So it is an overall hypocoagulable state. So the long R time denotes there is problem in clotting factors. The long K time denotes that the patient is deficient in fibrinogen. Low alpha angle MA is denoting that the patient is deficient in platelets. So we will consider transfusing FFP for clotting factor deficiency, cryo for hypofibrinogenemia, and platelets for thrombocytopenia. So this is a case of trauma-induced DIC. So the trauma has resulted into damage to vascular endothelium, which has caused release of large amounts of tissue factor and other procoagulants, which has led to consumption of clotting factors, fibrinogen, and platelets, and ultimately it has led to DIC. So this is a case of trauma-induced DIC.
Case scenario 8. A 42-year-old male is posted for liver transplant. During surgery, while inserting central line, there was oozing of blood from the IV side. A TEG and conventional coagulation tests both were sent immediately. This was the TEG tracing that was sent. The conventional coagulation tests showed a low platelet count of 23,000, elevated PT and APTT, and an INR of 1.5. Kindly explain this scenario.
So in this scenario, we can see the TEG. In the TEG, it is showing increase in R time. K time is also increased. There is decrease in alpha angle and MA is also reduced. So it is showing a clear-cut hypocoagulable state. So this patient was transfused with platelets and FFP.
The INR is showing 1.5. On what why is it elevated enough to give FFP, or why was FFP given?
So, in normal, if INR was 1.5, we would not have transfused FFP. That's why the TEG is showing increase in R time. So, it is showing that TEG is more superior to our conventional coagulation assays. So, in this case, if we compare it, the TEG with conventional coagulation assays, the TEG is showing a more accurate and a more accurate picture of the patient coagulation status. That's why we have transfused FFP. And after transfusing FFP and platelets, the R time has reduced, the K time also has reduced to a normal value. The angle has also increased and the MA has also increased after transfusing platelets and FFP.
Case scenario 9. A 63-year-old male with a history of myocardial infarction and unstable angina was scheduled for a CABG surgery with cardiopulmonary bypass. An EDTA sample was sent for pre-transfusion testing. The surgery was successful without any complications, but post-operatively there was persistent oozing from the surgical site despite administering protamine sulfate to reverse the heparin anticoagulation. The activated clotting time was 100 seconds, which was within the normal range. The anesthesiologist places a stat order for 2 units of single donor platelets, assuming that the cause of the ongoing bleeding is because of platelet dysfunction, which is a common issue in cardiopulmonary bypass. Meantime, the patient's sample was sent for a TEG, and this was the TEG reading. Kindly explain this scenario.
So in this scenario, we can see this is the normal TEG and this is the patient TEG. So the patient TEG is showing increased fibrinolysis, that is hyperfibrinolysis is going on in this patient. So they have transfused platelet to this patient, but it won't be a correct choice. An antifibrinolytic agent like intravenous tranexamic acid would be a better choice as the TEG is showing hyperfibrinolysis, which is the cause for bleeding in this case.
Case scenario 10. A 42-year-old male was admitted with crush injury. The patient was hypotensive during admission and required a resuscitative transfusion of 5 liters of normal saline. On admission, the patient was stabilized. His HB was 7.8, hematocrit was 36.7 and platelets were 1,41,000. His PT and APTT were elevated. A TEG was ordered. Kindly interpret this TEG.
So in this TEG, we can see this is a TEG trace in a patient with a crush injury. As compared to a normal TEG, we can see there is increased in R time. R value is prolonged in this case. It is 42 minutes and it is suggestive of coagulopathy due to hemodilution as the trauma has resulted in hemodilution. So it is suggestive of coagulopathy due to hemodilution, and the crush injury could also release endogenous heparin, which could also result in prolonged R time. So in this case, we have to transfuse FFP as it contains all the coagulation factors and it can prevent further hemodilution from occurring.
Case scenario 11. A 71-year-old male presented with sudden lower back pain and lower abdominal tenderness. An infrarenal abdominal aortic aneurysm was identified and duly repaired. Post-operatively, he was sent to the ICU and after 30 minutes, he began hemorrhaging. His platelet count was 1,82,000 with abnormal coagulation factors, that is decreased fibrinogen and a slightly elevated PT-APTT. Kindly explain the TEG that was done for this patient.
So in this case, it is showing a TEG trace in a patient with coagulopathy after an abdominal aortic aneurysm. So in this case, you can see the patient has low fibrinogen count and there is slightly increased PT and APDT. Now if we see the TEG, the R time is normal, the K time is prolonged and there is decrease in alpha angle. MA is normal in this case. So it revealed a normal R value, MA, but a prolonged K with a low angle. So in this case, there is problem in clot kinetics. Clot formation is normal, clot strength that is dependent on basically on platelet, that is normal, but clot kinetics is problematic, that is basically dependent on fibrinogen. So in this case, we will transfuse patient with 10 units of cryoprecipitate. So it was transfused in this case, which brought his fibrinogen levels back to normal, avoiding further hemorrhage.
Case scenario 12. A 30-year-old female patient was admitted to the MICU with the diagnosis of toxic shock syndrome. The nurses told that there was bright red blood oozing from her IV catheter as well as from her gums, and she also had some mild epistaxis. She was on mechanical ventilation. Regarding her vitals, she was hypotensive and tachycardic. A set of blood cultures were sent and her lab showed an elevated WBC count of 22,000. Her PT was 18 seconds and APTT was 47 seconds with a drop in platelet count. She also began exhibiting shortness of breath even when on ventilator and is clammy. A physician ordered a TEG. Kindly explain this TEG trace.
In this case scenario, the tag is showing with in a patient with DIC. So this is a plotted early DIC. The clinical picture of this patient is suggestive of DIC as there is oozing of blood from IV sites, from her gums, and also there is a drop in her platelet count. So this is a picture of early DIC which shows a hypercoagulable state, that is a short R time, a short K time, the angle is increased and the MA is also increased with secondary fibrinolysis. So it was showing a case of early DIC. The patient was given 4 units of FFP and the patient was progressive towards an hypocoagulable state, and the TEC in late DIC is shown in this picture. That is a hypocoagulable tracing, that is increase in R time, increase in K time, the alpha angle will be low and the MA will also be low. So this is a table which is showing how a TEC progresses in a DIC. First, in early DIC, we have a hypocoagulable pattern. That is, the R time is normal or decreased and there is increase in maximum amplitude. And as we compare this with traditional coagulation test, the fibrinogen levels will be increased and the platelet value will be normal or decreased. But in if it progresses to a overt TIC and a hypocoagulable pattern, all the coagulation factors, all the platelet will be consumed. So due to consumption of coagulation factors, we will see increase in R time. Due to consumption of platelets, we will see decrease in platelet amplitude, and this will also be reflected in a traditional coagulation test. That is, the platelet count will be dropped. There will be a drop in platelet count. There will be decrease in fibrinogen also. INR will increase and there will be increase in D dimer.
In early DIC, if the TEG is showing a hypercoagulable pattern, why we are not administering anticoagulants based on the hypercoagulable pattern of TEG?
So we have to see the clinical picture of the patient also. The TEG was showing hypocoagulable pattern. The R time was decreased, the K time was decreased, but you see that the patient was bleeding. So if we administer anticoagulant to the patient will further bleed. So in this case scenario, the patient was progressing towards an overt DIC. So to prevent it, we have to administer FFP to the patient.
True. Irrespective of the tests we do, ultimate judgment for transfusion should stem from both investigation as well as clinical status of the patient. TEG is a rapidly growing point of care test that is gaining importance in the recent years. Let's all be updated about TEG. Thank you.